Welcome. My name is Dr. Dan Irizarry. I'm a board certified family physician and I'm the medical advisor to Tactical Medical Solutions. I am so excited you're here. To be honest with you, this is kind of different for me. I've presented at IMSH a number of times, but never in this interesting setup that we have. I've had a lot of passion in healthcare and in treating casualties. I spent 26 years in the Army. One of the things that I had a great opportunity to do is work with a team of amazing professionals in Belgium. And what we did was we created a simulation center that allowed us to treat casualties from the point of injury all the way back to surgery on the back of an aircraft. And it taught me the importance of training the continuum of care. So I really wanted to focus on that in today's talk. Let's see. All right, that's not moving the slide. There we go. Tactical Medical Solutions, who are we? Well, Tactical Medical Solutions specializes in developing and manufacturing of a range of products. We're really three-pronged as a company. The one thing that we do is simulation. Now, you knew us as Trauma FX, but Tactical Medical Solutions acquired Trauma FX. And so now the simulation capabilities of Tactical Medical Solutions are the Trauma FX simulation capabilities you know well, the mannequins as well as the canines. Tactical Medical Solutions' original capability was really the creation of the soft T tourniquet, which is an important battlefield and pre-hospital and civilian EMS tool that is used to stop bleeding and severe bleeding. And then it developed over the course of time into a range of products that are available for pre-hospital care primarily. And then interestingly enough, the third prong of Tactical Medical Solutions is actually our protection product line, which is actually body armor, kind of an amazing body armor. So Tactical Medical Solutions as a company now is positioned to do simulation and training support with the right Class 8 and even protection. And one of the unique things about Tactical Medical Solutions is the way that Tactical Medical Solutions joins the first responder network. So we have a whole network of first responder trainers that are part of the Tactical Medical Solutions Nation. And we interact with those trainers all the time to assist with their training and supporting their training. So Tactical Medical Solutions is much more than just simulation, but it brings the power of both Class 8 supplies and other things in that network to improve your simulation. My goal for this talk today is really to help you think about how are you simulating the continuum of care. We're all good about simulating the individual scenario, that situation around the patient in a clinical setting when you're in the emergency department or the trauma room, or that point of injury. But rarely do we actually have an opportunity to do the entire process from point of injury all the way to the ER. But if you learn nothing else from this presentation today, I will tell you that there are a couple of things you can do by capturing small pieces of data that will help you to gather data over time that you can use to improve your systems. That's one of the ways the Army changed how we reduced our preventable combat death, and I'll talk more about that. The other thing that I would have you understand is that when I was building that simulation center in Belgium, one of the challenges was I didn't have a technology that had the durability and the realism and the physiology to go from the point of injury all the way to the emergency department. And now as the medical advisor to TacMed Solutions, I have the great pleasure of being able to develop those capabilities. And my good friend, Lieutenant Dan, is going to show you one of those capabilities later in this presentation. I want to set the scene for a minute. So simulation in the DoD, and you see some Marines using a mannequin here in a very far off place. Much like in the civilian world, we use simulation, as you probably know, to teach soldiers, sailors, airmen, and Marines rarely performed skills. Happily, in my 26 years of combat, we didn't have that many casualties, but we had to be 100% prepared for them. So having a simulator that provides you a realistic casualty was really important to creating skills and sustaining those skills. I trained medics most of my life and first responders. So one of the things that we wanted to do in our training was always give people a safe place to make mistakes. You do what you're going to do, whatever you're trained to do in tough and challenging situations. And so what we wanted to do is in Belgium and other training that we supported, is to create a safe place for you to make mistakes so you could practice it and get sets and reps. That was really important for us. The other thing is it was really important to exercise the casualty response system. Now, we tend to focus on the individual parts, ACLS codes in a very specific setting, or stopping bleeding at a very specific setting. But if as you all are well aware of, errors often happen in the transition points, the point from point of injury to being transferred to another person's care, or being transferred from the ambulance to the emergency department. So I wanted to, we in the Department of Defense wanted to focus on that continuum of care. And then we always wanted to have the ability to develop scenarios to improve judgment. All of these things for the Department of Defense easily translate into the first responder world that we work with in tactical medical solutions in the civilian setting for EMS. And I'm sure you can see that the scene is pretty similar, although maybe, and sometimes even tactically similar, where you might be in a harm's way, or in other situations that make it more challenging in the environment. I'm going to take a minute to talk about why realistic simulation matters. Sometimes when you train folks, in my experience, you only get one time to train that person. You only have a couple of maybe events in which you're going to have a opportunity to make an impact in that person's time, because time is very short, and it's really important to learn all you can when you've got these simulation assets in place. Realistic simulation engages that emotional response that you have to learn to manage in emergency situations. And so it's really important to have realistic simulation, realistic simulators, and a realistic environment as we do training. And so I'm going to show a video from CNN that talks a little bit about that.
Trauma alert, gunshot wound.
Let's get 2 liters of fluid. Pressure 84/56. Let's go ahead and intubate.
The sights and sounds of an emergency room.
Bobby, how you feeling?
Conditions that trauma doctors like Robert Benjamin are trained to handle. But this is not an average workday.
I had no idea that this was going to be that intense.
The trauma team is training. Their patient is bleeding and has rapidly changing vital signs. But he's not in danger of dying because he's not real. This is a high-tech patient simulator.
You were able to do a neuro check, moving extremities, looking at his eyes, breathing and respirations were very, very accurate.
All right, we're going to stop. Many times the learners know they're being trained. I'll just switch the scenario. I'll drop his blood pressure. What are you going to do now?
A control room team monitors the training, and the patient simulator's vitals are manipulated by remote control.
He lost a total amount of 1,500 milliliters of blood. His respiratory rate is now back up to 45.
Everything is recorded, giving the team video to review and an experience that could help in real life.
We need to build up more trauma teams, and they need to get to training in order to, become those veteran nurses.
We have another trauma on the way.
It's all staged, but for trauma training, this is as real as it gets.
So what's the problem with simulating the continuum of care? Well, one of the challenges that we sometimes find ourselves in, because of time or because of assets or because of what we have available to us, is we tend to learn and practice skills in unrealistic environments. And that's not a bad thing. Sometimes you do want to focus specifically on intubation and intubation skills in a crawl, walk, run phase, where the crawl phase is not, you don't have a lot of environmental factors in there, and you're just focusing on how to intubate a person. But when you get into the walk and the run phases, that's really in the EMS world and in the emergency department where you really need to be able to do those basic skills and then bring in those team assets, team communications, all of those different things that are important. We actually did a program with Trauma FX mannequins looking at a program called Squad Overmatch, where we improve the reaction of squads to both combat and casualty care by crawl, walk, run, but ultimately creating a very realistic scenario. The other thing is we fail to think about ways, even simple ways, that we might be able to assess or train the system. Most of us, at least when I was growing up, we waited for that once a year or twice a year mass casualty event. And we said, that's going to be the one time where we learn how the system works. But anyone who's actually been out in the field knows that if you don't practice these processes on a regular basis, and the small things in the system are what causes things to fail, then you know that that's a flawed concept, that we're just going to do mass cals at the end of the year, and that's going to mean that our system works. The other important thing is you just need to think about your training in a systematic fashion. When you're focused on that point of injury, think about what can you teach people about the system, the system and what's going to happen next. So at point of injury, it might be gathering very specific data that has an impact on the system. When you think about the system of healthcare, whether it's in the Department of Defense or whether it's in the civilian world, everything starts with a patient outcome, but you see there are steps in each of those processes, and every one of those processes are influenced by knowledge, skill, the ability of the people on the location, the team network, all those things come into play. So I would challenge you in your individual simulation centers to see if you can pick a couple of small things that represent failures in the system and check them on different training scenarios, different environments in the system. We'll talk about that in just a minute. So my learning objectives for you is to identify some of the current barriers to casualty response system training, many of which you can recite without problems because you do this all the time. I want you to identify just a couple of simple data points that if you measure them at each place that you train, you can create an aggregate of data that talks to you about your systems. I want to talk to you about listing 3 ways to improve continuity of care through your simulations. And finally, define some opportunities for return on investment when you do continuity care training. So this is a list that I'm certain you could make. Anyone who's done simulation in this world can in this setting with continuum of care can write this list. We never have enough time to simulate the whole system, so we try to focus on the parts. We require too much coordination. It takes a lot of time to arrange a fire department and an EMS ambulance and an emergency department and get them all sitting there at the same time. It's too difficult to measure objectively. A lot of simulation technologies that I've worked with, it's really hard to use them. You have to kind of gather stuff from a laptop computer. It's not intuitive to just simple data that I need to pull, that I can pull on every person and every person I train to look at trends across the system. We generally wait only until we have a mass cal planned, or we say, well, that's not the training that's requested. So we can't really do that because no one's asked us to look at systems. And sometimes we just don't have the right simulation tools. We say, oh, if I would do the simulation system, but to be honest with you, the simulation technologies I have, if I took them out of my simulation lab, they would break. Or vice versa. Oh, the simulation technology that I have, I can throw it off a building, it'll be fine, but it doesn't have the fidelity that you need to really train at a higher level of care. So really the goal, and the DoD ran into this problem, which I'm going to share, is to have a platform that can go through the continuum effectively. So how can we improve continuity of care training? Well, the first thing you have to do is you just have to open your mind. You have to be open to new things that maybe you didn't think about before. I know that when I started off, I was trained to do some very specific things, but training, for example, in Afghanistan with medics from different nations who had different skills and abilities, one of the things that I needed to do was I needed to create that continuity of care and to create that standardization. I needed a standardized platform that everyone could test against. And that was one of the beauties of one of the simulation capabilities that we used in the DoD, which we'll talk about more. It's all about having an open mind to what you have and how you can gather it. Along those lines, we always think about gathering information, sometimes subjectively, about, did you feel like this simulation was good? Do you feel like it'll help you to learn? Those are good things to gather, and they have value. But nothing speaks as clearly as data, hard, objective data. So, for example, one of the challenges that we ran into in the DoD was how soldiers just didn't know how to put on tourniquets, and they couldn't do it quickly. So just simply measuring across a broad spectrum of soldiers and ER people and everything else, how long it takes to put on a tourniquet, how much blood you lost in the process of putting on that tourniquet, or the failure to identify that your tourniquet wasn't tight enough and you were still losing a little bit of blood. Just that data point gathered at the point of injury, in the en-route care, and in the emergency department showed us that one of our critical problems in the DoD was making sure that we were able to stop bleeding. And that actually has impacts in the long term. So it's find some data or problem in your hospital setting or your setting that you can pick and gather it over a broad spectrum of people so you can see a trend that will make a difference. The other thing in the civilian world or in ERs might be, how long does it take for that person to identify that the casualty's gone into VFib and then subsequently done a defibrillation for that? So it's really about thinking systematically, what data can I capture that I can use over a course of time, and then be able to go to my administrators and say, hey, here's a fixable problem. And that's really important. And then really you have to invest in the right equipment. When we started this back when I was in the Army, I guess I joined in 1997, there was no trauma mannequin that would allow us to do these kinds of things. In fact, the Department of Defense developed its own trauma mannequin through processes that would be capable of sustaining the rigors of the environment and still provide us objective data. When I was finishing my time in the military, I worked very hard with a lot of great people to create something called the Tactical Combat Casualty Care Exportable Capability. And what this essentially is being used for in the Army is, much like I did in Belgium, a standardized platform to objectively measure the skills and abilities of first responders and medics to treat casualties in the battlefield and get them off the battlefield. This was really important because having a standardized one process really makes a big difference. And what's the return on investment? Is it really worth it? Well, it's absolutely worth it. First of all, many of you have probably heard that 24% of our casualties in the previous wars, most recent previous wars, were preventable. And that the 3 preventable causes of combat death were bleeding to death from an extremity wound, airway management, and objectively assessing an airway and putting in an nasopharyngeal airway, and tension pneumothorax. We actually had a unit in the United States Army called the Rangers, and what they did was they did 2 things. First, they objectively measured data meticulously on every real event that happened to their people. So this wasn't a scenario made up and based from their minds. It was Sergeant Irizarry, and this is what happened to Sergeant Irizarry on this objective, and this is what went wrong, and this is how it could have been done better, and this is how we fix it, and then they practiced that. So the first thing I would encourage you to do is, in every individual point in your continuum of care, pick real scenarios. The other challenge that we have in the Department of Defense is really managing the information flow from point of injury to the hospital. So they were really good at managing that information, and they could see trends where people had challenges, and they were able to fix the trends. The outcome of that, they had 0 preventable death. Let that sink that in. 0 preventable death. Across the rest of the DoD, about 24%, they had 0. But what they focused on was little pieces of data that affected the system. And that's what I am asking you to think about. Now, these 2 references you see here, I pulled them, and really what they say is this is a real problem for the pre-hospital setting in the civilian world. Most of our civilian counterparts didn't have access to the technologies that the Department of Defense has, but they could have access to those technologies. And we don't do a good job of picking that data and moving it across the continuum and thinking about that. The third thing that's not on this slide, but I want to thank two people. I kind of crowdsourced this question through the IMSH team about what's good ways to do this. And thank you so much for some of you who responded. But I want to point out something that both Mark Auerbach, who is a professor of pediatric and emergency medicine at Yale University, and Brody Verworn from Vitology Healthcare Education, they sent me some answers about their experiences, particularly in the pediatric world of doing EMS and testing the systems. And what they found was they were able to get grants focused specifically on training the continuum of systems. So Brody Brody actually told me when they provided the necessity of what they needed to do, they actually got significant grants to create a simulation center that was mobile, that could move through the states that they were in and would allow for that continuum of care treatment. So thinking about going to decision makers and saying, look, I'm not just going to tell you about how Dan Irizarry is fixing the problems within the emergency department or his challenges doing an intubation. I'm going to help you fix the systems by gathering the right data so that we can reduce error and save more lives. And so that's really the return on investment, ultimately, is saving more lives. So I want to quick shout out and thanks to Mark and Brody for contributing to that. So some final thoughts. Choose simulation and scenarios and platforms that provide realism, durability, and objective measurement. Really important that you have objective measurement and data in that. And choose data that you can capture over your different levels as you do simulation that you can use to create change, because data creates change. I'm Dan Irizarry, and I am so thankful that I've had the opportunity to spend a little bit of time talking to you about continuity of care across the continuum and some ways you can improve that. Here's my contact information and some of my teammates' contact information. Now we're going to transition to Lieutenant Dan, who has an excellent and long history in the world of law enforcement, and as well as a paramedic. And he's going to talk you through one of the technologies that we've developed that can serve as that stabilizing platform and testing platform from your point of injury all the way to your emergency department. Dan?
Thank you, Doc. Well, good morning, everyone. My name is Dan Stout, and I am currently the training manager here at Tactical Medical Solutions. Real briefly, what my background is: I grew up in Florida. I enlisted in the Marine Corps Reserve in 1989. Never deployed. Toys for Tots was about as Semper Fi as I got with that, but it was a great experience while I went to school. And then my wife and I both served for 25 years with the Gainesville Police Department, and we retired a few years ago, both as lieutenants. And I jokingly tell people that's the only reason I got promoted to lieutenant, just so they could mess with me and call me Lieutenant Dan. But it was a lot of fun. I spent a considerable amount of my time in the training unit, both as the sergeant and for about 5 years as the sergeant, and then went back to the road and then came back as the lieutenant and the training unit commander. So that's how I finished out my career. Spent a lot of time at the basic police recruit level, the police academy, in-service training, advanced and specialized training. One of the things that made my career a little bit unique, though, I was on our SWAT team at the time, which is a part-time team. And I was there when Columbine happened, not at Columbine, but I was on our team when Columbine happened out in Colorado. And that was a huge personal impact, professional impact. That was definitely one of those crossroads pivot points for our profession, just like 9/11 was. And a few months later, I volunteered to go to EMT school. Found out I enjoyed it, had a little bit of aptitude for it. So I stood on my head for the next few years and cross-trained as a paramedic. Civilian trained, traditional, ambulance-based EMS. While I was in school was when 9/11 happened, and that definitely opened up a lot of opportunities for law enforcement to train with federal partners, Department of Defense partners that we would not normally have done back in the 90s. So I got to go to some really good schools in that capacity that was more tactically medical based. At the height of both Iraq and Afghanistan, the operational tempo was very extreme, and the Army needed some assistance keeping up with the pre-deployment combat lifesaver training. So for about 8 years, I worked part-time 1099 classification for a training company, and 3 to 5 times a year, I would go off and do a week-long combat lifesaver training with the Army to help prepare soldiers pre-deployment, that type of thing. So I got a lot of really good experience doing that as well. So all of that to say, I have spent a considerable amount of my time in my career, both in law enforcement and in the EMS and in the DoD space, doing training from all different levels. And I definitely subscribe to and agree with the crawl, walk, run, increasing echelon of training. And my definition of crawl is you start in the classroom, death by PowerPoint. That's also where you're doing your hands-on skills in the labs, learning how to do the things. Walk to me would be all those different disciplines doing more training kind of in their silos. Law enforcement is over here doing law enforcement things. Fire's over here doing fire things. EMS is over here doing EMS things. When we get to the run stage, that's when we're trying to bring all of those disciplines together. Because what I've seen over the years is a lot of people make assumptions. We assume that on the day of days, when the red flare goes up and we have Pulse nightclub happen, or Mandalay Bay, or San Bernardino, or Sandy Hook, and the list just goes on and on and on, it's just all going to come together and work like a fine-oiled machine. And if you ever have the chance to go to any of those debriefs, there was a lot of things that went right. There was a lot of good, but there were a lot of things that got lost in space, and things that were identified that, man, I wish we had worked on this before, or we had no idea. We assumed this would happen and it didn't. So the more effort, blood, sweat, and tears you can put into the training on the front end, the better your personnel are going to be prepared for and perform when they really need to do this and not get shut down. Even our founder of TACMed Solutions, one of his biggest driving points to wanting to get into the world of simulation is to enhance training. Due to one of his worst days downrange, one of his medics kind of vapor locked in a scene because he got so overwhelmed by stuff that he had not seen. And basically Ross had to not only deal with what he was doing, but kind of verbally get this guy back engaged and on the right track doing what he needed to do. So the idea of being able to prep people as realistically as we possibly can so that it's not as sensory overloading for them when it's the real deal comes into play. Real quick, I did get a reminder as we're going through this, and I apologize if this didn't get brought up earlier. If you have a question about anything that Dr. Irizarry has said or anything that I bring up, any questions you have about the platform that I'm fixing to go over here, please enter those into the chat room, and we will just go through that list at the end of the presentation, try to get as many of them as we can for you. All right, so this system is the Trauma FX CRU CRL. This is one of our highest fidelity units. And Dr. Irizarry hit on this earlier. The idea of simulation is to have it as real, as high fidelity, and as rugged as we possibly can. Rugged, so that number one, this thing stays in motion, it continues to work, and we're not having to stop training because this thing constantly breaks and it doesn't work for us. This thing has to be able to stay functioning all the time. It has to be able to take a beating and keep on working. Some systems are out there that have to stay static. This one is meant to be carried, drugged, dropped up and down stairs. It will continue to function for you. It can be out in inclement weather, rain, sleet, hot, cold. It's a very rugged system, so very durable. You can go into your training day confident that the system's going to hold up. Real. This guy really does come across as a real human being that you're working with, both visually, texturally, sounds, everything that goes on with this guy, once we get him turned on here in a little bit, it makes it very, very real. Medically, the level of fidelity helps make what you're doing. Sorry, I've got a little bit of action going on here. Got a little distracted. My apologies. All right. The level of fidelity, what you can actually practice on this thing is amazing. Every advanced skill that's in the toolbox, you get to replicate and put it in play. I have done a lot of big scenarios, and you do the best you can with what you have where you're at. And it's kind of advanced over the years. One of the first big scenarios that we did where we put a lot of casualties out, literally somebody went to the shopping mall and got a bunch of old mannequins, like you put clothes on, just the little plastic shells, laid them out there, and there's little index cards with vital signs and their status of AVPU. And there was some level of moulage attempting to do that. That was great. Again, it's not in the classroom, it was out in the field. It was as realistic as we could make it at the time. But it was still dependent on, as SpongeBob would say, using your imagination, that type of thing. So it only went so far. And it also has a tendency for the student to still be reliant on an instructor. And in my opinion, making an instructor over insert themselves into the training versus the student looking up at the instructor and saying, does he have a pulse? Is he breathing? They'll see that the guy is actually breathing and actually he has the pulses, all that kind of good stuff. So it drives the student to actually take care of the patient, not the instructor that's standing there. One of the really awesome features that the system has is inside the head, there's a speaker and a microphone system so that the instructor can stand off at a distance and hear everything that the student or students is doing, but then can also serve as the voice for the mannequin. And again, I just think by adding that distance and getting the instructor away from the mannequin, that just helps keep the instructor from, again, being over inserted into the scenario and diminishes the student's reliance on the instructor and drives them to actually deal with the patient. The other thing about this system, I'll turn him on here in a minute in the remote control, there are some manual things you can do. But once you start the scenario, and there are a bunch of pre-programmed scenarios in the remote, and then this actually allows you to customize and develop your own scenarios. But once you push start, this system doesn't necessarily require a driver, meaning somebody standing there watching the scenario, trying to keep up with what they see the students doing, looking like they're playing Call of Duty. This thing is pretty much on autopilot. All the vital signs are what they are, the injuries are what they are. And then once the student or students start to do things medically, the system detects what is happening and it knows whether it's being done in a timely manner and correctly. And if so, it responds favorably. If the student is struggling, lost in space, doing things in the wrong manner, wrong sequence, the system starts to deteriorate and will eventually go all the way to a full code. And gives you a very detailed after action report as far as what happened when, what was being done, how effective or ineffective it was. It's an awesome way to debrief. But again, by not having to drive the system, letting it automatically do what it does, that does allow the instructor to be more visual and get a better understanding of what those students were doing. So just a couple of real quick safety points that I want to bring up just from my experience, and we'll dive back into this guy here. All of those systems need to come to play when you're doing one of these big events. Law enforcement, fire, EMS, the trauma center, whatever location we're doing this, be it an active shooter drill, wherever it is, public announcements, advertising. I think everybody has read or seen an article somewhere where some jurisdiction tried to do an exercise like this and not everybody was told it was happening. That never ends well. It's a miracle more people haven't been hurt in situations like that. So please, please, please advertise, road barricades with signs, safety tape, safety officers around the perimeter, and everybody that's in or close to the proximity of one of these things going down needs to know that this is going down. If law enforcement is involved, which they should be, you just need to factor in the fact that law enforcement, as part of their profession, carries firearms. We need to make sure that safety is taken into account and that real live firearms are removed, real live ammunition is removed, and repetitive over and over and over again to ensure that no live weapons, no live anything is getting entered into the training scenario. We were running a building clearing training day once at an industrial complex, and there was an older veteran officer that just thought all of the safety protocols that we were taking were unnecessary, and he was just giving us lip all day long, all day long. We broke for lunch, we came back, we repeated all the safety protocols over again, and I could hear him about 4 or 5 people back down on the line. You had to get patted down 3 times by 3 different people. I was the first one in line, and when I got down to his ankle, I found a loaded .357 Magnum revolver on his ankle. It's kind of like the scene from Full Metal Jacket where Gunnery Sergeant Hartman finds the unlocked footlocker, and basically says, if it wasn't for people like you, there wouldn't be any thievery in this world. Similar type situation. He and I had a moment, and so we wouldn't have to do all of this type of stuff if it wasn't for people like you. So that was probably not the most professional moment of my career, but it got the point across. Please be safe when you're doing these types of things. All right, so let's actually get this guy fired up here and put him into play. And we're going to start at the head and work our way down so you can see some of the different interventions and things like that that are going on. So his pupils react. All right, they constrict and dilate to light. You can fully put an NPA. And one of the cool things we can do is we can make it available. We can make it available for a certain amount of time, and then we can take it away. So if they're dragging their feet, we can actually make it so that it becomes unable to be able to place the NPA. Same thing with the intubation. They get it for X amount of time. We can make it an easy intubation. We can make it a difficult intubation. We can take it away, which makes them drive towards doing a surgical crike. But as far as the airway goes, one of the things I like about this system is I've done a lot of intubation training over the years on different things, and it's great, but it feels like a hunk of plastic. You know you're dealing with a hunk of plastic, and it just doesn't feel right. It doesn't feel right to the touch. It doesn't feel right with the laryngoscope. The airway on these systems were developed by an anesthesiologist so that they are, I'm trying to get the flashlight as best I can here so you can see down in maybe. There we go. There we go. Sorry. This is the wonders of doing this online. Sorry, guys. So it reacts, it looks right, it feels right, the jaw moves right, the tongue is malleable. You can do it correctly, you can do it incorrectly, and the system will respond accordingly, but it's fully intubatable. The teeth have the alarm so that if you're cracking teeth and all that type of stuff, you'll know it. And again, that's just the way the jaw is. The tongue feels like a real tongue. And again, once the laryngoscope's down in there, it just feels like you're dealing with a real airway. So it's just a really phenomenal tool. Again, we can take that away, which drives them to do a surgical crike. And one of the cool features about this, when you're making your incision, we can do something as cool as this. All right, I got a little excited there. All right, but when you make your incision, it'll bleed and you're able to do your full surgical crike. As far as IOs go, we have a sternal IO, humerus IO, and there's one down on the leg below the kneecap. You can do bilateral needle decompression, and the scenario will actually develop to the point that if they don't deal with the sucking chest wound or we have a tension pneumothorax develop, the breathing will increase, that side will not go up and down. So they should be picking up on the fact that they need to do that. Once they successfully do it, if it's done in the right way and in the right location and within a timely manner, once they insert the needle, they get the hiss and they actually get that side of the chest back in play. Really, really cool, awesome feature. We have functioning sucking chest wounds. It gives them the opportunity to fully bandage up and seal up a sucking chest wound. On the right arm, you can actually start a fully functioning IV. There's a chamber in there that has the simulated blood so that when you insert the needle, you get a flash in the needle and you can actually push 500 cc's of fluid into the mannequin. Going back to the scenario that I described where we were using just plastic mannequins from the shopping mall, obviously there's very limited as far as what you could do as far as treatment goes. Basically, the way the medic would handle that is they would get all of the materials out for an IV, but tape it to the arm, but they didn't get the actual insertion of the needle and get the red flash and all that kind of good stuff. So that's a really cool feature. This model does have blood pressure, so it has all the vital signs: pulse, respirations, blood pressures, O2 sats. You can actually take a blood pressure with a blood pressure cuff. It's really cool. It has carotid pulses, radial pulses, and pedal pulses, sorry. It also has the feature that as the patient begins to deteriorate, they will lose radial pulses, and then they can still find the carotid pulse. On this side of the patient over here, actually on both sides, you can do chest tube insertion. All right. We inserted it on the patient's right side. I'm pulling this one off the left side so you can see that there's an actual film on the inside that replicates that pop that you have to go through to get the access point for the tube to go in. Now you'll see that this arm has burns on it, stuff like that. One of the things that we can do is customize the way the mannequin comes. So if you didn't want an arm with burns, you don't have to get an arm with burns, but that's just the way this one is set up. So moving down to the lower unit, and you'll see right here, there's a gap. I just have this pushed together. Right now, he is an upper and a lower that can be separated into task trainers, or I can actually connect him on the inside and he becomes one solid connected unit that will actually bend at the waist, which is a really cool feature. Some things are just meant to be solid planks and they sit there in a very plank manner. This guy can actually bend at the waist, which is really cool. So as far as the injuries on the legs, the things that are happening, we have an inguinal wound that can be packed. All right. This one particularly has an amputation, and that is meant to drive the students to apply a tourniquet. All right. This particular model as well has the fully included scrotal injuries, and it is capable of taking a Foley, right? And then also down here, I mentioned earlier, the tibial IO access point. So what I've done with this system in the first responder setting, and it is, I apologize, it is also fully articulating and animatronic. So it's not just a mannequin laying there on the ground, not doing anything. It will sit there and articulate and move and buck and even be a combative patient if you need to. So you can rely on somebody to have to help hold the patient down while you're attempting to do interventions on them. So again, coming back to what have I done with this system in the first responder space. And again, this is backing up what Dr. Irizarry talked about earlier about testing the continuum of care. We set up and designed the scenario so that law enforcement would be on scene going to, quotes, stop the violence. They pushed through the building, and there were other casualties that they had to pass to get to the area. They dealt with and eliminated the threat. They stopped the violence, but this guy right here was the last casualty in the room that the, quotes, bad guy had inflicted injuries to. So this patient had to be treated by the law enforcement that was on scene. They started what they were trained to do at a BLS, TCCC, TECC level type training: tourniquets, bandages, chest seals, hemostatic agents, that type of thing. They were on the radio, they were communicating where they were at. We were able to bring in fire and EMS under an NFPA 3000 rescue task force configuration where they are now coming into the warm space, cold, warm, hot, under law enforcement escort to be able to do the handoff where law enforcement is handing this patient off to the fire and EMS. They were able to do the skills at their level on this patient. They were able to intubate. They were able to start the IV. They were able to package this transport up in an extraction device and get them off the X and get them moving. In that particular scenario, this guy went by ground, all right, and was handed off to yet a different set of EMS personnel. So they got to then deal with this guy in the back of the ambulance, and it showed all the way up at the trauma center. And we're able to take him into one of the vacant trauma bays so that the ER staff there could then get busy with him and get hands-on. They could do the more higher level things such as the chest tube, adding the Foley, and continuing the care of this patient. So that was a really awesome way that everybody in that system got to be hands-on and touch this patient. The other time that we did this, it was really cool. We were specifically wanting to do something for the ER staff that was kind of off the wall a little bit. And they kept expecting this guy to come in on an ambulance, come in on an ambulance, come in on an ambulance. Well, we did the whole citizen pulls up into the Sally port and drops off the casualty and then takes off. Literally just dumped him outside the trauma bay. So the ER staff had to come out, scoop the guy up, get him in. So they were the first ones to actually get medical stuff other than a t-shirt wrapped around him by the citizen that just dropped him off and dumped him in the Sally port. So they got to do everything from start to finish, which they just thought was cool. And it was really awesome. Let me show you one more thing here about the touch screen remote. All right. So this is the way the system works. And I apologize, I'm going to try to do this upside down. You can see it's very easy. It's just touch screen technology now. But wanted to show you this specifically for the ACLS type stuff. Once we get it into this mode, you'll notice over here, all right, this thing is programmed to do the 12 megacodes, and you can do full ACLS codes. It will respond accordingly to all of the different ACLS drugs that are administered. You can, with a adapter, hook this thing up so that it will run off of your monitor, or you can use one of our monitors to do your ACLS type stuff. But it is a really awesome tool to be able to do the mega codes, and the after action report on this side of the screen is set up in the American Heart Association format. So it will definitely help you when you're doing that type of review and after action report and things of that nature. As I mentioned earlier, the system comes with pre-programmed scenarios, which are phenomenal. The other thing I like is that you can actually program in customized scenarios and things like that. So if your people have a weird call, a one-off, that type of thing that comes up at grand rounds or quality assurance, you can go back in, create that scenario so that all the personnel get the experience of going through that training and seeing what it was that those particular set of staff got to deal with that day. So again, that was just a real quick down and dirty explanation of what we're trying to accomplish with this system and test all the different parts of the continuum of care and how this can be touched by all of those different levels. I'm fixing a mask up here because Dr. Irizarry is going to come back and join up. He flew on an airline yesterday. I don't know what kind of cooties he got. So we're going to be here and available for any questions that came up in the chat room. So whatever we can do, if there's a question in the chat room, if anybody's got a live question, please let us know.
Yeah, so far we've got no questions. Dan, great job talking through this technology. I think one of the key things that I learned about from your talk is really the preparation, right? Making sure that you have the right tools in the right place. Safety is really an important piece. I think that was really a valuable contribution to the concept of training this continuity of care. And I guess the things that I take from this is, this mannequin is a relatively new system for us. Most of the folks that probably are familiar with Trauma FX are really focused on the first responder. You might remember the mat with two that are missing two limbs and things like that. But this really is a capability that can take you all the way from the point of injury as a standardized platform and gather that data at every step. And that's why I'm a huge supporter of using this capability. The other thing is, getting this capability available to you. One of the things that we've recognized is a challenge is being able to afford a full system. And so we're actually working on rental processes and other mechanisms to make it easier to get these capabilities to folks and use them in your systems.
Absolutely. A couple quick points I just wanted to add. From my experience over the years, there's two types of people that have opinions about training. Some that love it and some that hate it, okay? And as an instructor, obviously you're trying to teach to everyone, and you have to manage the difficult, challenging students, the folks that, quotes, really aren't into it, really don't want to be there. They're just there to check the box. One of the things that I have seen this type of training do is even awaken those more challenging, difficult students. When they see the effort that goes into this and they get to see the benefit of the training and how it's affecting them and improving their skills and making it as realistic as you can possibly make it, the general reaction, even from those more difficult, challenging students, is that was the best training I've ever had in my life. We should do this every month, not understanding, the logistics that goes into pulling off, one of these the full Monty type training that we're talking about doing. But it also, the feedback that I've gotten from them over the years also is, 6 months later, a year later, year and a half later, somebody will come back to me and say, hey, that training that we went through, I worked a crash, I worked a shooting, I worked a stabbing, and it was just like the scenario that we did. And, thank you for making me better able to handle that and things of that nature.
So Dan, we got some questions.
Okay, go ahead, Doc.
Right. So the first question was, can the injured limbs be swapped out or are they fixed from the factory? So yes and no. Certain limbs can be switched out, and we are working on other mechanisms to switch out limbs. But for example, certain limbs you can buy a sleeve so you can kind of get rid of wounds. Other wounds we can plug, so we can make them less noticeable using plugs like this. So, and we also have other types of limb configurations. So you have different types of wounds for lowers and uppers. So one of the great things about this system, in my opinion, I'm dating myself, but when I was a kid, we wore something called Garanimals. And as long as you had the right top and the right thing, and it was the right animal, you could match it up. This has different uppers and different lowers. So you can buy the fidelity of upper or buy the fidelity of lower with and connect them, and they all work together off of this central capability. We actually even have a capability that allows you to run up to 20 mannequins all at the same time if you wanted to do that. Second question, and thank you so much for the questions. Please keep sending them. How far can you get from the mannequin with the remote? I've been told 100 feet. I've seen it go farther. It's pretty good. I've never had a problem getting far enough away from the person so that they felt alone. And that's really the biggest piece of it, is feeling alone. I mean, not being able to look over your shoulder and see the instructor. In fact, one time I was demonstrating this for a 4-star general, and we were about 20, the person operating the mannequin was about 20 feet away, and he had a real visceral experience, broke out in sweat because he didn't know how this thing was running. Do the wounds bleed? Yes, some wounds bleed, depending on the wound. So as you mentioned, this wound in the inguinal area bleeds. There's a tourniquetable, we have the tourniquet on right now, but the amputation will bleed. We have a bleeding amp arm, an amputation arm that will bleed. It's not on this mannequin. So not all of the wounds bleed, but there's enough wounds bleeding that you can use tourniquets, and you can use compressive hemorrhage and other capabilities to realistically simulate bleeding. And interestingly enough, with the pressure, we also have this set up so that the pressure, you have to put enough pressure on physiologically to stop the bleeding. It's not just, oh, I touch it briefly. You really have to hold pressure. We even measure how long you hold pressure. So for example, in a hemostatic dressing, you have to hold pressure for 3 minutes. We can make you hold it for 3 minutes and keep that real. And if you lose pressure, it starts bleeding again. So it's built on realism. Someone said, if so, how is the bleeding fluid loaded for the bleeding? So a little hard to show right here, but inside here, kind of right there, you can see a tube, and then we have a bucket that connects, and it feeds into that, connects into that tube right there.
And for all the technology the mannequin has,
Right
this is
there.
old school gravity fed out of a bucket in a tube, which makes turnaround time on the scenarios important, so that people aren't sitting around twiddling their thumbs, humming, waiting for their next turn. Somebody goes through it. It's a very quick reset, maybe 5-6 minutes, and you're ready to go and this guy's fully capable of going again. So quick turnaround times on the fill.
And the simplicity of the system means it's going to be reliable in terms of filling. That's kind of one of the challenges is you make things more complex, you make them easier to break. This is developed, and you can see even the metal and the connectors here. This thing is developed specifically for the ability to withstand trauma, so to speak.
Going back to the remote question real quick. The touchscreen remote is an upgrade, is a new technology for us. Just went into effect here not that long ago, and it was a dramatic increase on the distance. It went from about 100 feet to 200 yards is the distance that you can be away from this guy and actually still control him with the touchscreen remote. So it went up a considerable amount of distance.
Yeah. Lisa, so first of all, Dwayne Patterson, thanks so much. Carrie Hale, thanks so much. Lisa Atkinson, thanks for your question. Can he be changed to a female? He can. It's not pretty. We'll be honest with you, because when he was originally designed, it started off with a lower because the Army needed a lower, and then they made a really big lower. So to make it proportionally, we made him a big upper, and he's about 6'2", and normal weight for a 6'2" guy. But yeah, we do have a capability that will allow for realistic breasts with the same capabilities, same sense of skin that's real. In fact, the breast attachment actually has a wound underneath the inferior portion of the breast, so that people kind of miss it. And the training point is to make sure that you check in those places to look for wounds. And then we can actually switch out the genitalia as well. He's not a pretty person, but he can certainly be female. How heavy is the full body?
He's 180 pounds.
180 pounds.
Which feels like 300 because he is completely dead weight. He is a sack of pudding with bones in him. So it's a very heavy system, very realistic. It was obviously intended to be a lean, mean fighting machine, young military DOD type fit. But that's the weight on him right now is 180 pounds.
Keep the questions coming. We love them.
They are available, and we have done this. They can be made in any ethnicity that needs to be done. We actually sold 20 of these units to the Tokyo Police Department, and we actually made them Japanese. What happens here from the neck up, the person is actually brought in and casted where they are covered in the plaster, and they have to breathe through the straw for 4 hours. So when we sent these over to Tokyo, it was representative of the population that most likely that police force was going to be encountering. So we have that capability of any ethnicity that's out there.
So the legs moves, but the arms don't. But one thing that we didn't mention is some of the clinical sounds. So we actually incorporated into the clinical response unit breath sounds. We also incorporated some heart sounds. You can use a real blood pressure cuff, as he mentioned. And in bag valve mask mode, you can actually manage him with a bag valve mask. And it changes the SATs and things like that. If you're not bagging him fast enough, his ETCO2 will go up, his PO2 will drop. All those things that you would expect for someone who's not bagging a patient appropriately actually happens. Let's see.
I think we skipped a question. It says, please show his feet.
Please show his feet.
Nathaniel, can you zoom in on his foot?
He has 1 foot. We'll show his foot. Thanks, Lisa. Can sounds be recorded and played through the speaker rather than having a person speak on the? Absolutely. Let's see. Can sounds be recorded and played through the speaker rather than having a person on the mic? Yeah, I've never tried that. It never really occurred to me to do that. One of the nice things about the two-way mic is that you can get far enough away from the patient that you can actually talk to the person. In fact, one of the things that we did to the general was we had the operator say the general's name in his first name, which is very unusual to call a four-star general his first name. But that really shocked him. He was not expecting to have that personal interaction. But I'm sure if you did probably take the sounds and put it next to a mic, you could probably make the sounds come out. Now the challenge is those sounds would come from the mouth or from the head. But if that's the sound you're looking for, yeah, definitely you could do that.
Somebody's wanted to see him start moving around.
Can you show him become combative bucking? Oh yeah.
Basically from the hips down.
Yeah, let me see that for just a second. I'm just kind of curious.
And I will say, a lot of the times where I've used this in training, that catches people completely off guard. They are not expecting him to start moving like that. And they'll actually say he's moving. Oh my gosh. And the person's trying to put the tourniquet on, and watching them have to figure out and solve the solution about how do we get this tourniquet on somebody whose legs are kicking, because they've just been used to somebody standing there with their arm out like this, trying to get a tourniquet on, or just a standard piece of plastic mannequin that doesn't move. You see their eyes open up significantly.
So it's actually also pretty sensitive motion. Pull in here. So our joystick for the movement, you can put it on automatic movement, it'll just move. But when you put the joystick on, even just a little bit of motion, you get a little bit of motion. But if I do big motions on the joystick, I'm going to get big motions. And in the directions that you want to get them. So you could actually kind of simulate consciousness in that way. You know, so if a person was moving a lot initially and then they started to move less and then they just stopped moving altogether, a way to simulate consciousness.
So the last question that's up there says, do you get urine back from the Foley placement? And the answer is yes. Just like there's a chamber in the arm to facilitate getting the flash when you're starting the IV, there's a chamber in here for the blood to come out of the leg and the inguinal wound. On the unit that has a bleeding arm, there's a chamber for that. There's actually a chamber down here in the abdominal cavity that holds yellow urine that will come back out of the Foley once it's properly placed.
Are we done with time?
We're right at an hour and a minute, so I'm not sure where they're at.
We're at an hour and a minute on time, so we're just doing the time check. I think can you do a rectal exam? No, you can't do a rectal exam that doesn't have a rectum in it. Could you put blood in the area? Certainly you could, but you can't fully insert. We've talked about that in future options as we improve over the course of time. So let's see, are there any other questions? I'm thinking no. Okay, well, we're just going to pull up our contact information on our slide again, I think is what we're trying to do here. So you can take a screen capture of that. And it's also being recorded. So let's see, we're getting to it.
Just a quick review for everybody.
Oh.
There
you go. So, hey, my name's Danny Rosari. It has been my pleasure to spend a lifetime trying to save lives in challenging situations. Same thing with Dan. I guess we're Dan and Dan.
Dan and Dan.
There you go, Dan squared. We've had a great time providing you this presentation about continuity of training the system. We hope it's valuable for you, and we hope you've picked up a couple of nuggets that you might be able to use in your own settings to try to find small pieces of data that make a difference, and look at technologies that will stand up to the continuum of care. And I'm really interested in talking with Mark and Brody and others more about what ways you can fund these things. I was pretty impressed at the grants that they got for being able to train the continuum of care. It's an important part of the system, and in the civilian world, it may not be as tested as we could. I'd also encourage you to come to our virtual booth. We have a virtual booth and where you can see more of the technologies and talk with people who can answer more of your questions. I'd also like to finish up with thanking IMSH and the Society for Simulation in Healthcare. Without an organization like this that brings the academics of simulation together with the technologies of simulation, we would not be anywhere near where we need to be. And we've got a lot of work to do. We need to save a lot of lives, and this is how we do it.
Appreciate your time, everybody. Thank you for your patience in this world of Zoom meetings and Zoom training. I appreciate that you're willing to do this, and look forward to the day and the opportunity where we can get back face to face and let you all get hands-on and do it that way. So again, thank you for your time, and we really appreciate it.
Bye.